Good morning, respected dignitaries present of the dais, our highly esteemed guests and faculty members and doctors. May I have the honor to invite our chief guest of the day, Dr. Professor Vinay Kumar sir, on the stage. May I also invite our principal of the institution, Dr. Ranjit Guha sir, to come up on the dais. I would also request our president of the Bihar and Jharkhand chapter, ISGCON, Dr. Ramesh Chandra sir. I would also request our Dr. V.M. Dayal sir to please come up on the stage. And I would also request Dr. Manish Mandal sir to please come up on the dais. It gives me an immense pleasure to extend to you a very warm welcome on behalf of Bihar and Jharkhand chapter of ISGCON 2023, whose commitment and exuberant efforts have brought the doctors across India under one roof to share their intellect.
When darkness comes, let us not condemn the dark, but light a lamp to illuminate. On that note, we would like to invite our eminent guests present on the dais to kindly come forward for lamp lighting.
मेरा सर नहीं आ रहा देखो हाँ आ रहा है आ रहा है मेरा सर देखो ना छोटू मेरा सर आ रहा है हाथ आ रहा है आ रहा है
सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्डमहाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्डमहाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
लाल चढ़ायो अच्छा गजमुख को दिल लाल विराजे सुत गौरी हर को हाथ लिए गुड़ लड्डू साई सुरवर को महिमा कहे न जाए लागत हूँ पद को जय देव जय देव जय जय जी गणराज विद्या सिद्धाता धन्य तुम्हारो दर्शन में राम नगरता जय देव जय देव
Thank you, respected dignitaries. We welcome you all to the Indian Society of Gastroenterology Conference 2023, the Bihar and Jharkhand chapter.
Commencement of the conference, may I have the honor to invite our chief guest of the day, Dr. Professor Vinay Kumar, the director of our institution, to show his guidance and share a few words with us. So please.
Very good morning, all my friends, seniors, colleagues, ladies and gentlemen. The dignitary on the dais, Dr. Ramesh Chandra, the President of Association of Indian Society of Gastroenterology, Bihar chapter. Bihar and Jharkhand chapter. Dr. B.M. Dayal, Dean Academics, DDA and Medical Superintendent, Dr. Manish Mandalji, Dr. Ranjit Guhaji, Principal, and my friends sitting in the audience. It's a great moment, a very pleasant moment and an honor for me to stand before you for this inauguration of the workshop and 2 days the conference of Bihar and Jharkhand Indian Society of Gastroenterology. Being a proud and esteemed member of this association since 90s, I joined in 1995 as a full member of Indian Society of Gastroenterology. I have been associated with this association not only physically but literally. We have many publications, the official publication of Indian Society of Gastroenterology, Journal of Indian Society of Gastroenterology, the most prestigious one and high impact factor. This meeting, I'm sure, will bring a platform and bring the ideas, give a networking and professional development for everybody who is attending this. And this professional development will not only work for the development of the individual's skills and modulating their practice, but also serving NIDAs for doing better work in the future. Such type of conferences, of course, will also bring the public attention and generate awareness among the public about the developments which is taking place in the field of gastroenterology, one of the most sought after disciplines in medical practice. I wish all great good luck to all of them who are participating, and I'm sure after the 2 days conference, people will be more wiser, more enlightened to pursue their course, their procedures, and their skills will be more uplifted by participating in this conference. Thank you very much.
Thank you so much, sir, for your valuable words. Moving on, I would also like to invite Dr. Professor Ranjit Guha, sir, the principal of our institution, on the podium to share his insight about the conference.
Very good morning, one and all. Honorable Director and Vice Chancellor IGIMS, Professor Dr. Binde Kumar sir, and very esteemed Professor Dr. Ramesh Chandra sir, who doesn't require any introduction, and our esteemed Dean sir, Professor B.M. Dayal sir, and Professor Dr. Manish Mandal sir, our esteemed DDA and Medical Superintendent, and all the esteemed and erudite gastroenterologists of the state who came across from different nooks and corners of the state and assembled here to celebrate the inaugural ceremony of the annual conference, 29th of its kind, of Indian Society of Gastroenterology Bihar Jharkhand chapter, in a very ceremonious manner. So I am really delighted that I have been given the opportunity to be a part of this inaugural ceremony, and this type of conference always provides a platform for exchange of ideas and thoughts and sharing of recent information, and also confers opportunity to keep ourselves abreast with the recent updates. So I think the way the organizing team has organized this event, the gala event, leaving no stone unturned, it will definitely be a grand success with the participation of so much of delegates from different nooks and corners of the state, and there will be all the invited speakers. There are important deliberations are there on the recent updates of, from the GI field, gastroenterology field, and I also congratulate them and express my gratitude and indebtedness and thankfulness to the organizing team and to all the participants, delegates, invited speakers, and all the supporting staff, media, sponsors, and print and electronic media. So thank you very much. I wish you wonderful success.
Thank you so much, sir. Now, may I have the honor to invite on the podium Dr. Ramesh Chandra, Principal of Bihar and Jharkhand Chapter, ISGCON. He is also a renowned consultant gastroenterologist in Ranchi.
our teacher, Dr. Dayal sir, and my friends, colleagues and delegates. This is the 29th conference, Bihar and Jharkhand chapter, Indian Society of Gastrology Department. I appreciate in high words our organizing secretary, Dr. Vijay, for his endless efforts since last 2 months and his team. I hope this conference would be a great successful, although we are seeing a little low audience support here, but we have a lot of interactive sections and workshops, seminars, group discussions, cases in this conference in the coming 2 days, and I hope all the delegates and speakers and all persons attending the conference will have great impact in their clinical life and teaching life. I wish all success to this conference. Thanks to Dr. Vijay and organizing team. Thank you, sir.
I would like to extend my thanks to Sir for his valuable words. Now, I would like to invite Head of Department, Gastroenterology, Dr. Professor V.M. Dayal Sir, to put forward his valuable opinion and ideas among us. So please come up on the dais.
Good morning, everybody. Our respected director, Dr. Binde Kumar, President of the Association, Dr. Ramesh Chandra, who has come all the way from Ranchi, our Principal, Dr. Ranjit Kua, our TTA come MS, Dr. Manish Mandal, our guest faculty in the audience, Dr. Malay Sharma, Dr. Vikas Singla, and all other faculty, students, guests. This is a kind of a habit that we are making, and this is the third time the last 6-7 years that we are holding such a conference. And I'm sure that all of you who will take part will go back much enlightened, because not only are we having theoretical sessions, we are having a workshop as before, and the latest techniques in the field of gastroenterology, endoscopy would be demonstrated, and I hope this will inspire you, all the participants, the delegates, to learn these procedures and start doing them on your own patients. CMEs and workshops of this kind are very important. They are not only mandatory under NMC, but we know that medical science is continually advancing. There are so many papers published every day, new techniques, new methods, new knowledge is coming out, and it's difficult to keep track. So events like this, which kind of gives you a concise view of what is happening in the world of gastroenterology, the new developments, the new achievements, are very important, because not only do they give you more learning, but based on this learning, the treatment of patients would improve, and ultimately the whole society benefits. So I must congratulate Dr. Vijay Shankar and Dr. Ravi Kant for doing the hard work behind the scenes to put this all together. I am sure it will be a grand success. Thank you.
Thank you so much, sir, for your valuable words. Now, I would also like to invite Head of Department of Surgical Gastroenterology, Dr. Professor Manish Mandal, sir, to share his foresight with us. So please come up in the dais.
Good morning, everybody. Respected Director Sir, Dr. Professor Binde Kumar, our Dean Academic, Dr. V.M. Dayal Sir, our Principal, Medical College, Dr. Ranjit Guha, our President of ISG Bihar Jharkhand chapter, all the dignitaries of the dais, especially our guests who have come all the way from different parts of Bihar, Jharkhand and India to share their knowledge on this today's very important ISG Bihar and Jharkhand chapter state conference. My dear friends, colleagues, residents, others. It is proud privilege to me, not only as a faculty, as superintendent, as a member, as an ex-president of the association, to host this program at this place, IGMS, from where this ISG Bihar Jharkhand chapter was born. And when I joined around 23 years back here, then the first association which I joined was this ISG chapter, Bihar Jharkhand chapter. And we, along with the then head of the department, Dr. Aminda sir, Dr. VM Dayal sir, worked hand in hand, Dr. Manoj sir was there, hand in hand, to make this association very strong, very effective, and for the first time we took it to the grassroots level. ISG Bihar chapter function was there every week once before COVID times. So we had a lot of learning in past, we are still learning today and we still be learning and making this association a great achievement for the people who are still joining. ISG Bihar Jharkhand chapter is the only chapter where all the people are taken care of. जो नया एंट्रेंट है उसके लिए भी उतना ही हेल्पफुल है, जो पुराने लोग हैं उतना ही है. And all our presidents, vice presidents who have given their efforts and pain to make this association very vibrant. I especially thank Dr. Vijay Shankar, who has been working day and night like one-man army, although supported by everybody, but one-man army. He had to run all the way from pillar to post to get this program set as he had called for. And from last 3 days, he is on his, I think, in 12 or 14 hours more days at IJMS only, seeing that everything is just right and just apt for it. Thank you, one and all, for inviting me here.
Thank you, sir, for sharing your experience and enlightening us about the golden past of ISGCON. This is my firm belief that guidance and support of our senior doctors will surely make this event a massive success. I would kindly request our dignitaries to please be seated off the dais as we begin our sessions for the day. We are very much grateful for your valuable presence. The Conference of Indian Society of Gastroenterology and Oral and Poster presentations. In our first session, we will have 2 live workshops. May I have the honor to invite our revered chairpersons to come up on the dais. Dr. Bimal Kumar, Senior Consultant Gastroenterologist, Patna. Dr. Manohar Lal Prasad, Department of Gastroenterologist, REMS, Ranchi. Dr. Sanjay Kumar, Additional Professor in Department of Surgical Gastroenterology at IGMS, Patna. Dr. Amritesh Kumar, Senior Consultant Gastroenterologist in Patna. Dr. Sudhir Kumar, Assistant Professor in Department of Gastroenterology at AIMS, Patna. Apology. It's Dr. Avinash Kumar, Senior Consultant Gastrologist, Mahavir Hospital, Patna. It would be my honor to call our first speaker of the day, Dr. Professor Manisha Dwivedi, to please come up on the dais. Dr. Manisha Dwivedi is a renowned gastroenterologist and currently she is a professor at Motilal Nehru Medical College. With over 200 publications and 3,000 citations, she has been vigorously involved in research. Her core interest lies in liver cirrhosis, endoscopy, gastrointestinal diseases, esophageal diseases, IBS, biliary tract diseases, etc. Her topic for today's discussion is management of intractable hiccups. May I kindly request ma'am to please begin with her speech.
Thank you. Good afternoon, everybody. I must congratulate the organizing team for this conference for coddling up a very interesting, exciting academic program, which I think you surely will, this will enrich you and you will leave enriched tomorrow. I'll be talking to you about intractable hiccups over the next 20 minutes. First of all, what is a hiccup? It is a sudden erratic contraction of the diaphragm together with the intercostal muscles so that air rushes into the lungs. Simultaneously, there is a closure of the vocal cord just 0.25 seconds after the diaphragmatic excursion. This vocal cords close together with a hic sound, and that is what is a hiccup. Usually this is a self-limited problem. However, if it persists for more than 48 hours, then you will say that this is persistent hiccup. And if it is persistent for 1 month, then this is labeled as intractable hiccup. In a retrospective study, 55 out of 1 lakh patients had a primary diagnosis of hiccups. It is more common in diseases which affect the GI tract or the central nervous system. And it is present in about 20% cases of Parkinson's disease and 10% patients with gastroesophageal reflux disease. Prevalence in advanced cancer is to the tune of around 5%. In patients with esophageal malignancy, nearly 25% patients have intractable hiccups. This is more common in men than in females, and when in females there is a definite psychogenic component to it. It has been found to be more in taller people, people above the age of 50 years. However, there is no racial or geographic variation. The pathophysiology. This is a reflex arc. The stimulation is by the central and the peripheral nerves via the efferent limb, which go to the central processing in the brain, and finally there is an efferent limb to the diaphragm and the respiratory muscles. The afferent nerve is the phrenic and the sympathetic nerves from T6 to T12. The central area in the brain is the midbrain, involving the periaqueductal gray and subthalamic nuclei, and the efferent nerve is the motor fibers of the phrenic nerve to the diaphragm and the accessory nerve to the intercostal muscles. This is how the CNS lesions can cause hiccups. The higher centers, that is the midbrain, medulla, the medullary reticular formation, the phrenic nerve nuclei and hypothalamus, if there is a lesion there, then the central processing would be abnormal. Similarly, if the input from the phrenic and the vagus nerve is affected, again there will be problems in the stimulation to the brain. Also, if there is a pathology which affects the thoracic viscera and the abdominal viscera, again the signals would be a problem. The pathway and the functioning of this reflex arc is by serotonin, and once this is processed, it gives the efferent fibers take over, giving rise to repetitive myoclonic contractions of the diaphragm and accessory muscles of respiration from T1 to T11 affect the external intercostal muscles. Once these efferent fibers go to the muscles, there is a reflex closure of the glottis resulting in hiccups. The hiccups are due to irritation of the reflex arc, either by a lesion along the pathway or by drugs or by systemic conditions. The efferent motor fibers in the recurrent laryngeal branch of the vagus nerve cause this glottal closure. And in this, multiple neurotransmitters like GABA, dopamine, serotonin, glycine, histamine, epinephrine, and acetylcholine are involved. The etiology of persistent hiccups, there is a long list. It comprises of vascular tumors, inflammatory conditions like meningitis, encephalitis, vascular tumors, trauma, This is in the central nervous system. In the peripheral pathway, it can be affected in the chest cavity, heart, the gastrointestinal tract, and even post-surgical, you might have these intractable hiccups. Chemotherapy might be responsible, and drugs like anti-Parkinson's drugs and psychiatric medications. Also, instrumentation in the form of atrial pacing, catheter ablation or CVP catheterization, esophageal stent placement could also cause these hiccups. And then there are miscellaneous causes like electrolyte imbalances, and of course ethanol use is another big cause, tuberculosis and chronic renal failure. Coming to the gastrointestinal and abdominal disorders, gastric distension, GERD, infectious esophagitis, peptic ulcer disease, gastric outlet obstruction, pancreatitis, there's a whole long list that could cause this. And we've already talked about the CNS disorder, which could be vascular infectious, and there could be lesions which are compressing the medulla like aneurysms and syringomyelia. Also demyelinating disorders like multiple sclerosis also could cause this. The drug-induced hiccups could be because of dexamethasone and diazepam. Always remember that benzodiazepine should not be used in the treatment of these refractory hiccups. Tramadol methyl dopa might cause it. Also chemotherapeutic agents like fluorouracil, oxaliplatin. How do you evaluate these patients clinically? You see for the duration of symptoms, the impact they have on eating, sleeping, disturbances, and then you try to figure out whether these hiccups are related to a definite organ system like the CNS, pulmonary, cardiac, GI, etc., or it is because of drug intake or psychiatric symptoms, and then you do a clinical examination. If you find a cause, then it is easy to treat the cause first and then of course to manage the hiccups. If there is no cause, then of course you'll have to do the whole gamut of investigations, starting from blood electrolytes, ECG, then try to see for localizing symptoms. If you find a localizing symptom, then you do a targeted evaluation. For example, in GI, if there's a GI involvement, you can do an upper GI endoscopy, abdominal imaging and pH studies. And if you don't find any localizing signs, then you have to image the brain, chest, abdomen, and of course the GI tract. Management entails various stages. First of all, if you find a localizing cause of this, then you treat that underlying cause. Number two, you graduate on to non-pharmacological methods of quelling this problem. Subsequently, pharmacological means, and last of all is the invasive procedures. The non-pharmacological means are to stimulate the nasopharynx by rapid water swallowing, swallowing sugar, very cold water, or doing a gargle. You can induce vagal stimulation by eyeball compression, carotid massage, or the Valsalva maneuver, or you could try to interrupt the respiratory cycle by breath holding. Coming to drugs, chlorpromazine is the only drug which is approved by US FDA to treat this problem. It is given in a dose of 25 to 50 milligrams IV or IM. However, there is a word of caution that before you start chlorpromazine, the patient should be well hydrated, and you must give them at least 1 or 2 units of normal saline or dextrosaline to keep him hydrated so that he doesn't develop hypotension. Other drugs which are useful are haloperidol, gabapentin, valproic acid. Again, baclofen is very useful, given in a dose of 10 milligrams 3 times a day. Metoclopramide also in a double-blind trial was found to be effective, and so was nifedipine. Baclofen is a GABA agonist, decreases the excitability and inhibits the hiccup reflex. It is an effective drug, to treat this problem. However, a sudden discontinuation after long-term use might precipitate convulsions, so you should taper the dose. And it was found that there was a complete resolution in 18 out of 37 patients and a significant improvement in 10 patients. Invasive procedure comprised microvascular decompression of the vagus. There is also an implanted vagus stimulator that could be used. Phrenic nerve blocks can be utilized. Unilateral is preferred. Nerve block with local anesthetics can be done, or you could even do a nerve crushing. However, the prerequisite is that there should be a functional hemidiaphragm on the other side. To summarize, history taking is very important, especially the history of drug intake, coexisting illnesses. Examination should try to find out the cause of this, and then you should do the serum electrolytes, creatinine, and the other investigation. If there are no localizing features, then as we said, a CT, chest, abdomen, head, gastroscopy should be done. Treat underlying cause, and as we said, first the non-pharmacological means, then the pharmacotherapy, the drugs that we talked about. Usually this is an innocuous condition which is frequently ignored. Complex pathophysiology is there, therefore multiple medications have been tried and used. Most effective ways to find and treat the etiology if you can. Self-help techniques like ice water intake, breath holding also can help. And then the various treatment options like the medical, non-medical and surgical. Baclofen also may be considered as a first-line therapy, followed by gabapentin, and of course chlorpromazine is very effective. Thank you.
Well, the talk is open for discussion. Any questions, comments, queries? And then
Sometimes it does not stop even after giving all the drugs. What can we do?
Yes, you are right. But then after all this, I don't think you can do anything much.
Excuse me, ma'am. Ma'am, sorry for interruption, but question answer session has been scheduled at the last of the session.
Okay.
Thank you, ma'am.
Thank you, ma'am, for your extensive. Ma'am, please be seated on the dais itself. Excuse me, ma'am.
Moving on, may I have the honor to invite our second speaker of the session, Dr. Srihari Anikhandi on the dais. Dr. Srihari Anikhandi is a gastroenterologist and hepatologist working in Sri Gangaram Hospital, New Delhi. His expertise are in the fields of advanced endoscopy, narrowband imaging, and GI mobility manometry. His interests lies in liver diseases, cirrhosis, hepatocellular carcinoma. His topic for today's discussion is evaluation and management of esophageal motility disorders. We kindly request him to please begin with the speech.
A very good afternoon to everybody. I am extremely grateful to the organizers for giving me this opportunity to present on this wonderful platform. I bring greetings from Gangaram Hospital, and I am here to discuss on esophageal motility disorders, evaluation and management. Though 20 minutes might not be adequate to discuss, but I will be covering the most important aspects of this topic. So when we talk of motility disorders, the food that we eat it goes down by propulsion due to the coordinated peristalsis of the esophageal body. Plus there is a deglutitive inhibition of the lower esophageal sphincter, which aids in the movement of this food bolus down into the stomach. So when we talk of esophageal motility disorders, the problem is at either of these two places. One, that the coordinated peristalsis of the esophageal body is not occurring, or second, there is a problem with the deglutitive inhibition of the lower esophageal sphincter. Now when we talk of esophageal motility disorders, previously we had the Chicago third version, which divided these motility disorders into major disorders of peristalsis and minor disorders of peristalsis. By major disorders, they meant that these are those motility disorders which actually have clinical implications, and minor disorders meant that there is a motility disorder but it might not yield a clinically significant event. So the major disorders were achalasia cardia, EGG outflow obstruction, distal esophageal spasm, jackhammer esophagus or absent contractility, and the minor disorder of peristalsis was ineffective esophageal motility. That means if you had esophageal motility disorder in a patient, that might or might not be responsible for the patient's symptoms. The latest Chicago 4 version of classification of motility disorders has classified these motility disorders into other categories. They have classified them into disorders of EGG outflow obstruction, which include achalasia cardia and EGG outflow obstruction, and disorders of peristalsis, which include absent contractility, distal esophageal spasm, hypercontractile esophagus, and ineffective esophageal motility. So whenever we are evaluating for any patient who comes with dysphagia, usually the first test is always an upper GI endoscopy. Then comes your esophageal manometry, and in today's era, barium swallow might not be a very useful test because manometry has taken over and it gives us the reason for dysphagia in most of these patients. So when you do an endoscopy in a patient with motility disorder, it is common to find very obvious signs like there is a resistance at the lower esophageal sphincter, pooling of secretions of saliva, grossly dilated esophagus with a large amount of food residue. What is most important in these situations is that we should have a very good retroflexed view at the GE junction to rule out any infiltration or pseudoachalasia which might be leading to these motility disorders. But sometimes, despite doing a good endoscopy, you can never be certain that what is the reason for dysphagia. So here is a case where the endoscopy apparently looks normal, was reported normal at 2 other centers. This patient had frank dysphagia. But if you look very carefully, there is pooling of some amount of saliva, there are some tertiary contractions that we can see, and there was a very subtle resistance at the lower esophageal sphincter, and this was a patient with proven achalasia cardia. So we can miss these disorders when we do an endoscopy. The role of barium, classical signs that are seen on the barium are a parabolic appearance in achalasia cardia. You can have a corkscrew-like appearance in spastic motility disorders like distal esophageal spasm or jackhammer esophagus. A timed barium swallow is an extremely essential test when we talk of motility disorders. What is done in a timed barium swallow is to see the height of the barium column at 1 minute, 2 minutes and 5 minutes. When we talk of height of the barium column, it is not the entire height, but height from the maximum site where the barium is homogeneous. So you measure the height from the lower end up to the upper end, and it has been seen that the residue of barium of 5 centimeters at 1 minute has a sensitivity of 94% and a specificity of 71%, whereas 2 centimeters at 5 minutes has 85% sensitivity and 86% specificity for diagnosing achalasia or EGG outflow obstruction. It is also useful to assess the efficacy of treatment for achalasia cardia, where you should have at least a 50% reduction in the height of the barium column at 5 minutes in the post-treatment time bariums. There is something called as the use of a barium tablet, and this has now overtaken the timed barium swallow in the West. A barium tablet is a 13 millimeter impregnated tablet, and if you have a retained barium tablet at 5 minutes, it is thought to be 100% sensitive for ruling in or ruling out achalasia and EGG outflow obstruction. Then comes the most important test for diagnosing motility disorders, that is the manometry. The manometry setup looks something like this, and there are 2 systems available in the market. One is the water perfuse system, wherein the catheter looks a bit more bulky, and some places as of now have a solid state catheter which is easier to handle, easier to use, easier to install, but it is very expensive as compared to a water perfused system. Most of the systems in India, more than 90% use water perfused manometry system. So what is there in a water perfused manometry system? is a setup like this. Basically, it contains a water chamber, which is the heart of the manometry system, and this water chamber contains degassed water, and there is air or gas which is coming in through a tubing at a certain pressure. This pressure is monitored by the gauge here. It is usually 1 atmosphere, and this water is being propelled under certain pressure through an intricate system of capillaries that you can see in this panel over here gradually. So this is being propelled under a certain amount of gas, and it goes through these various capillaries, and all these capillaries are then eventually connected to one catheter which has multiple channels, and there is water dripping through all these channels at different sites. So basically what the manometry observes is what is the resistance to the flow of water at the various sites of interest. So when you do an esophageal manometry and the catheter has gone inside, you can see the pressures occurring at various areas of the esophagus. So initially there were line graphs like this where you could see that there is a high pressure zone starting from the top, and as the bolus propagates forward, it goes down and down and down. So what you see here are the channels that we saw on the manometry catheter. But it is important to understand that the events which are occurring in the body are in 3 dimensions. So actually what is occurring is something like a 3-dimensional event and not a 2-dimensional event like this. But it is very difficult to see a 3-dimensional event on a 2-dimensional screen, on a computer screen which is 2-dimensional. So what they did is they gave colors to these different areas of pressure. So on a manometry graph you can see different colors. So there are warm colors and then there are cool colors. So warm colors are blacks and reds, and cool colors are greens, yellows and browns. So here if you see, compare this with this, the esophageal contraction which is going across, you see this high pressure zone which is going across like this. This is a constant high pressure zone at the upper end, which is the upper esophageal sphincter, a constant high pressure zone at the lower end, which is the lower esophageal sphincter, and as the contraction enters at the G junction, the lower esophageal sphincter is relaxing, and this is a normal esophageal contraction. How do we diagnose achalasia cardia? Now in achalasia cardia, the problem is the LES does not relax. So in all types of achalasia, it is important that the lower esophageal sphincter is non-relaxing. Non-relaxation of the lower esophageal sphincter is determined by a parameter called integrated relaxation pressure, or IRP. For convention, the IRP cutoffs are taken as 15. Anything more than 15 is abnormal, but this might not be a very strict cutoff, and it varies according to machines and according to the type of achalasia. So in type 1 achalasia, you have a non-relaxing lower esophageal sphincter. The patient has taken a swallow, the LES has not relaxed, and you can see that there is no contraction in the esophageal wall. In a type 2 achalasia, you have seen that the patient has taken a swallow, there is a break in the upper esophageal sphincter, there is non-relaxation of the lower esophageal sphincter, and there is no contraction. This is not a contraction, this is the bolus just dropping down like that, and what we are seeing here is the intra-bolus pressurization and not the contraction. This is called as the pan-esophageal pressurization. In type 3 achalasia, what happens is the peristalsis is too fast. So instead of the peristalsis going down gradually like this, it appears in rapid succession, and this is a premature contraction. So you have a high IRP, non-relaxing lower esophageal sphincter, with a premature contraction, which is type 3 achalasia cardia. So various modalities exist for treatment of achalasia cardia. Previously it was the pneumatic balloon. Botox was there for some patients. Now POEM has become a very popular modality. Laparoscopic Hellers done by surgeons. So talking about pneumatic balloon is a non-radio-opaque graded polyethylene balloon in three sizes, 30, 35 and 40 millimeters. Mind you, it's a graded pneumatic balloon. You always start with the lower diameter and then go on to the higher diameters in subsequent sessions. The problem with pneumatic balloon was thought to be perforation rates, but the perforation rates with a 30 millimeter balloon is not that high. As the size increases, the risk of perforation goes up. Response rates with a pneumatic balloon are of the rates of 90% at 6 months, so you have good response in the initial phases, but as the time goes by, there is a tendency for it to come back. This is probably because of the incomplete disruption of the muscle fibers. Then comes the next two most important modalities, that the POEM and LHM. I cannot discuss that in detail because of short of time, but most importantly, success rates of POEM and laparoscopic hillers even on the long term. Now we have studies of for up to 7 years and they are almost equal in efficacy of up to 90%. There is a huge talk about the risk of reflux esophagitis. POEM has been shown to have higher incidence of reflux esophagitis as compared to laparoscopic hillers. But the bigger question is how many of these are significant reflux. Most of these reflux patients are mild reflux which can be managed very easily, and there is only a very small subset who have LA grade C or D reflux esophagitis. Very small conditions where an LHM might score better over a POEM might be a sigmoid esophagus, patients with esophageal diverticulum, or those who have an associated hiatus hernia. Botox injection is used as a modality for patients who are extremely frail with an ASA grade of more than equal to 3. The technique is using 100 units of Botox which are divided into 25 units each and injected in 4 quadrants. There are no major adverse events usually with a Botox injection and it's safe. The response rates are good at 1 month. So you have around 80% response rates at 1 year, but it's usually short lasting, and by the end of first year the response rates are limited to only around 40%. So if you have a type 1 achalasia or a type 2 achalasia, all 3 modalities might be more or less similar. But if you have a grossly sigmoid esophagus, you have a type 1 achalasia with a grossly sigmoid esophagus, especially S2 kind of a sigmoid where you can see 2 loops or 2 curves of the esophagus on imaging, here laparoscopic hillers might be more useful, or sometimes you might have to go in for an esophageectomy. Whereas in a type 3 achalasia cardia, it is very clear that a POEM scores much over a laparoscopic hillers because here you can tailor the length of myotomy. The problem in type 3 achalasia is the problem lies not just at the sphincter, but the lower esophageal muscles are also contracting very vigorously, and you need to do a longer myotomy in such patients. So POEM scores over laparoscopic hillers. Of course, if the patient is very frail, elderly with multiple comorbidities, Botox is the treatment of choice. Then comes to hypercontractile esophagus. So hypercontractile esophagus is where the esophagus is contracting very vigorously. You don't want the esophageal muscle to be contracting too strong. And this is diagnosed by a parameter called distal contractile integral or DCI. So when the DCI is more than 8,000, that's a hypercontractile esophagus. There are 3 patterns which are seen. And the classical jackhammer esophagus is where you can see multiple crests and troughs like this, like a jackhammer machine. And this is a classical jackhammer. Previously all were called jackhammer, but according to Chicago 4, these are all hypercontractile esophagus, and this classical pattern is what fits into a jackhammer. Now for hypercontractile esophagus to diagnose, symptoms are a must. According to Chicago 4, that patient should be presenting with dysphagia or chest pain. Hypercontractile patterns could be heterogeneous. In fact, you also have a pattern where the hypercontraction is only at the area of the lower esophageal sphincter. The LES area is contracting very vigorously. All hypercontractile esophagus are not jackhammers. And when you think of treating such patients, you should always try for a medical treatment before being too aggressive with an endoscopic or surgical treatment. That is according to the latest guidelines. Distal esophageal spasm is where the contraction is occurring too fast. This is where the distal latency is low. So the normal wave should have been like this, gradual, but here it is occurring too fast. Mind you, pure distal esophageal spasm is very rare. It is often a part of type 3 achalasia. Now if you take 10 swallows and if you see that most of these swallows are showing DS pattern, then your confidence to diagnose this increases. You take 10 swallows in a normal conventional manometry tracing, and it is important to realize that sometimes opioid may be a cause of distal esophageal spasm, and this can be secondary to reflux disease. So it is treat the reflux before you actually plan an intervention. In ineffective esophageal motility, there is a clear-cut guideline now how to diagnose. This is different as compared to Chicago version 3, where they have clearly laid cutoffs how to diagnose an ineffective esophageal motility. Now there is a new test called as augmentation test on manometry, where you do something called as a multiple rapid swallows. So this is a normal swallow where this is the DCI. In multiple rapid swallows, what you ask the patient to take 2 ml, 2 ml, 2 ml, 2 ml of water 5 times, and at the end you would see a swallow which is much more augmented as compared to the baseline. So here the DCI would be more than the baseline swallow. So if there is a augmentation after multiple rapid swallows, that means patient still has an esophageal peristaltic reserve, and this is extremely important in patients with GERD. If you are planning a wrap, you should not do a 360-degree wrap if this patient does not have a post-augmented multiple water swallow augmentation. So how do you treat such patients? So patients who have spastic disorders like hypercontractile esophagus or DES, or ineffective esophageal motility or absent contractility, the first thing should always be to be evaluate for an underlying GERD. Don't just rush on to treat such patients, because POEM is an option and it looks very promising that you treat these patients with POEM, but evaluate for underlying GERD, optimize your PPI therapy, and you might consider dilatation if dysphagia is there. If GERD is not a prominent symptom, then you see what is the most important presenting symptom of the patient, if it is whether it is dysphagia or whether it is chest pain, because many patients with spastic motility disorders do present with non-cardiac chest pain. It is very important that chest pain in such patients responds poorly to POEM procedures. These are most likely, this will most likely respond better to tricyclics or other antidepressants. However, if the patient is presenting with dysphagia, the options include EGD with dilatation with or without Botox, and if still does not improve, POEM or pneumatic dilatation might be considered as the last option. EGG outflow obstruction is one interesting entity. Now, the problem with EGG outflow obstruction was previously many esophageal motility disorders were diagnosed as EGG outflow obstruction without any apparent cause. So up to 10% of the patients were diagnosed as EGG outflow obstruction according to Chicago version 3. But most of these patients, 1/3 of these patients are spurious diagnosis. This is because of catheter artifacts. Mind you, there can be a lot of artifacts when you do a manometry because of mechanical effects like an hiatus hernia, and these do not require these do not require any specific treatment. A very small proportion of EGG outflow obstruction are actually early stage achalasia, and this you have to be very careful when you diagnose an EGG outflow obstruction. So here is an example. So this is a patient who has a small hiatus hernia. Here you see that there are two high pressure zones at the lower end. This is the LES, this is the pleural diaphragm, and this small hiatus hernia is what is causing a non-relaxation of the IR of the lower esophageal sphincter, and this was falsely labeled as an EGG outflow obstruction. So there are very clear cutoffs. So you should have manometric diagnosis of EGG outflow obstruction. It should be considered conclusive if you have a manometric diagnosis in primary as well as in secondary positions. So secondary positions are erect or changing the patient to lateral. Patient should have clinically relevant symptoms like dysphagia or chest pain, and you should have at least one supportive investigation like a TBE or an endoflip, which is as of now not available. So here you see that this patient in the right lateral position showed features suggestive of EGG outflow obstruction, but when the patient was shifted to upright, this EGG outflow obstruction just vanished. Similarly, one more case in the supine position versus the upright position. In the upright position, it is showing EGG outflow obstruction, but in the supine, EGG is not seen. So treatment options for EGG outflow obstruction: first, only treat EGG outflow obstruction when artifacts are actually ruled out. 50 to 70% of patients with EGG outflow obstruction will have spontaneous resolution. Botox, endoscopic dilatation, and very rarely POEM might be useful. So ladies and gentlemen, the take-home message is there has been a renewed interest in esophageal motility disorders in the recent years. This is because of advanced diagnostics like high-resolution manometry, which have helped us understand the motility disorders better, and knowledge of pathophysiology of motility disorders helps us to improve the treatment options. Thank you, sir.
Thank you, sir, for your deep insights on the topic. We kindly request you to be seated on the dais itself. We now hereby are open for discussions on the topic, and we also invite queries from our informed audience. We now request our chairpersons on the dais to set about the discussion.
Use ketamine in a dose of 0.4 milligrams per kilogram, that is 1/4 the anesthetic dose, and that might help.
Thank you. Any PGs over here? How do you do a carotid massage? Never do it bilateral, you knock off the patient. Do it on one side. So that's very important. I can share my experience. I have one patient. I had put down endoscope in esophagus. I felt I am not in esophagus, I am in stomach. His esophagus was full of food and very difficult to clear that esophagus. So what can be done in this such type of cases?
So this is a common scenario in end-stage atresia or patients with sigmoid esophagus. There are 2-3 things that might help. One is changing the position of the patient. When the initial test being done in a supine position, you can ask the patient to sit up. We have also tried taking the endoscopy, taking a foreign body forceps, holding the tip of the esophageal manometry, not below, because there are channels there. The tip don't have any channels, and then just pushing it across, and then bringing out the endoscope by wriggling movements, not straight, otherwise the catheter will come out. And sometimes left or right lateral position, and asking the patient to swallow some liquid might help. But despite doing all this, sometimes yes, it is sometimes not possible that the catheter goes beyond. Then you might have to rely on other ancillary testing to diagnose.
I'll tell you a very practical method of doing it. Pass a biopsy forceps under vision and take it across the G junction. Or you can pass a balloon and then glide the scope over it. You will work of that.
Can I make a comment? So nowadays we have wire guided catheter also. You do the endoscopy, just push the wire into the stomach, and over the wire you can pass your manometric catheter. That is
He's talking about the endoscopy. He's not talking about the manometry. Thank you, sir. Thank you.
On the computer derived report.
That is absolutely.
And I have one query. While the considering the efficacy of assessing the efficacy of POEM or other invasive procedure for the patient of esophageal motor disorder, so do you consider the effect of the parameters like DCI to decide the efficacy of that POEM procedure? Like, would you consider the IRP more than 15 with DCI less than 100 had same effect as compared to IRP, raised IRP with DCI more than 500?
So, sir, coming on to the first part of your question, that you need to understand many parameters before you do a manometry, but actually these are only 4 parameters which you need to understand. One is IRP, one is distal latency, one is distal contractile integral. These are the 3 most important parameters that you need to understand. If you understand these 3 parameters, you can diagnose any motility disorder on a manometry. Second is the role of DCI. So it is only the IRP, or some studies say the baseline LES pressure, which matters when you do a POEM. Because in type 1 and type 2 achalasia, you are only dealing with the lower esophageal sphincter. You are not much interested in the myotomy. But in type 3 achalasia, which is a spastic motility disorder, here the DCI tends to be very high in certain patients. And in these cases, spastic motility disorders, that are type 3 achalasia and jackhammer esophagus, where the DCI matters. So if it's a type 1 or type 2 achalasia, I am not worried about the DCI. In fact, you cannot find a DCI in type 1 and type 2, because what is happening in type 1 and type 2 is an absent contractility. In absent contractility, you usually don't get any DCI. Whatever contraction you are seeing is not the true contraction of the esophagus, it is the bolus of the food which is giving you that pressure on the manometer. It is not the esophageal contraction. So that is not the DCI which you see on type 1 and type 2. It is an intra-bolus pressure. Though the machine shows it at DCI, that is not DCI.
Compared to high RP like the 2025. Then post-dilatation, can we use a prognostic marker? Success of the post-dilatation.
So more than prognostic marker, I think it will give you a very satisfying result. A patient with a very high IRP, and then you do a procedure and the IRP suddenly falls down and patient has a substantial relief of his symptoms. More than prognosis, I think it is the outcome which actually.
And what about, sir, recurrence of symptom after doing the post-dilatation? Is it work in 6 months, the recurrence is more in high IRP patient, baseline high IRP patient than the low IRP
yes,
patient?
I think theoretically that might be true, because high IRP might actually correspond to a more thicker sphincter at the bottom, more muscle bulk at the bottom, and the balloon dilatation might not be sufficient to break all those fibers. So I think now POEM has taken over at most of the centers where expertise is available. Balloon, I think, is hardly done these days.
Ma'am, a question for you. We are dealing with the intractable hiccups. each and every test is normal for the patient, like the MRI, brain, upper GI endoscopy, everything. Patient have we given baclofen, you said the first line, and patient have no control of the hiccup. Then what is the algorithm of the management after baclofen? What we should give and after that what we should give it?
But as I told you, the various drug fluorpromazine is very effective. It is effective in 80% of cases. Also, you could use a combination of fluorpromazine plus olanzapine. In several studies, that also has been found to be effective. There's no hard and fast rule that after this you give this, but you have a gamut of medicines and you can try any of them.
IV is better than oral in that for both chlorpromazine and olanzapine in intractable hiccups.
Chlorpromazine IV is definitely better. Olanzapine you can give orally also.
Okay, ma'am. Thank you.
Again, practical tips. Table hiccup is reported to be 63 years, and ironically, that patient died hours after he had stopped hiccup. And you cannot say with confidence that I am going to cure your hiccup.
The patient died because hiccup stopped because the patient was dying. The patient died and the hiccup stopped.
This marks the end of our. This marks the submission of our first session.
We would like to request our chairpersons sitting on the dais to present the memento of appreciation to our speakers. At first, I would like to request Dr. Manisha Dwivedi ma'am. Ma'am, please come forward. And we would like to present a memento of appreciation. Now, we would like to request Dr. Srihari Anikhandi. So please, we would like to honor you with presenting our memento of appreciation. Now, we request our speakers as well as chairpersons to come forward for the photography session. Thank you so much to all the delegates present on the dais, on the chairpersons and the speakers. Moving on to our second session of the day. May I have the honor to call our chairpersons of the session number 2, Dr. Vikas Prakash. He is a senior consultant gastroenterologist and director at PIG Apollo Spectra Hospital, Patna. Dr. Ramesh Chandra. He is a senior consultant gastroenterologist in Ranchi, Jharkhand. Dr. Naresh Kumar. He is head of department of medicine at IJMS Patna. Dr. Avinash Kumar Singh. He is a senior consultant hemato-oncologist at Paras HMRI, Patna. Dr. Govind Kumar. He is associate professor, Department of Medicine, IJMS Patna.
Now, I kindly invite our speakers of the session to please come on the dais. Dr. Sandeep Nijhawan sir. Dr. Sandeep Nijhawan is a senior professor, head of Department of Gastroenterology at SMS College, Jaipur. He has held some of the most prestigious positions such as National President of Indian Society of Gastroenterology. He has developed a wide range of indigenous endoscopic accessories and instruments which are very cost effective. His expertise lies in therapeutic endoscopy, ERCP and EUS. His topic for discussion would be evolution strategies of chronic small bowel diarrhea. I kindly request him to please begin with.
And at the outset, I'd like to thank Vijay and the team to actually invite me. Wherever I go for any talk, I meet my students and my hemoglobin goes up. But whenever I come to Patna, there are many of my students here, so I get polycythemia vera. So keep calling me and make me happy. So today I have a different topic, that is chronic small bowel diarrhea, how to evaluate. As far as the definition of chronic diarrhea is, if it is more than 4 weeks of persistence of diarrhea, it is chronic diarrhea. Then it depends on the liquidity, fluidity and the frequency. So it's not only the frequency. In India, even a normal population, people go 1 to 2 times a day, and it is normal for them. And 9% of the healthy population have 3 or more stools. So it is not only the frequency, but the fluidity also matters. And as far as the weight is also concerned, the Indian average weight of stool is 311 gram per day. So we have to actually take into consideration where we are practicing. So we have to take proper history, examination, then actually categorize where we are as far as the chronic diarrhea is concerned. Then we do certain laboratory tests, stool analysis followed by management. So as far as the etiology is concerned, we have diffuse mucosal disease, celiac disease, tropical sprue, immune deficiency, and that causes parasitic infections, Whipple's disease, IPSID, autoimmune enteropathy, HIV enteropathy, and Crohn's disease. As far as the luminal phase is concerned, we have chronic pancreatitis leading to actually chronic diarrhea, bile acid diarrhea. Then transport phase, that means there is some problem in lipid transport like lymphangiectasia, abital hypoproteinemia. A study done in Mumbai has shown that tropical sprue still persists, and it is one of the major causes of chronic diarrhea in India. And of course the other causes, which include celiac disease and other diseases. And a study done at AIMS have shown that celiac disease now has become more common as a cause of chronic malabsorption syndrome. It's around to the tune of 64%, followed by 22% as tropical sprue. Then there are certain uncommon causes. So as far as the diagnostic approach is concerned, there are few questions we'll be answering one by one, reaching to the final diagnosis. So functional or organic, any patient who has got a long history, there are no constitutional symptoms, appetite is normal, there is no weight loss, there is no nocturnal diarrhea, they have more of gastrocolic reflex and anxiety symptoms than it is a functional diarrhea. If somebody has got a short history with mild constitutional symptoms and losing weight, and there is a decrease in appetite, nocturnal diarrhea is there, one should always think of an organic diarrhea. Then volume and content of the stool is also important. Frequency and function of the rectum is to hold the stool. So any patient with a rectal disease will have high frequency. As far as the volume is concerned, it can be high or low volume. And content, it can be purely watery or it can be a mixed form of stool. So any patient who has got a high frequency with a high volume and a watery diarrhea is a secretory diarrhea. And any patient who has got a high frequency with a low volume and is a mixed content is a large bowel diarrhea. And a mixed thing like normal or high, frequency, volume normal or high goes in favor of small intestine. And mind you, small intestinal diarrhea is not always voluminous, at times it can be a small volume diarrhea. So we have to take into consideration other points also. And then there are differences between diarrhea, chronic diarrhea because of chronic pancreatitis and mucosal disease. In patients with chronic pancreatitis will have pain, they have a history of diabetes, they do not have any constitutional symptoms, they are not so common, and they have oily stools. And anemia and hyperbilirubinemia is less common as compared to mucosal diseases, where actually the anorexia, weakness, systemic symptoms are out of proportion to diarrhea, and there is presence of anemia and hyperbilirubinemia showing us the features of malabsorption. Then it should be painless or painful. Painless, all mucosal diseases like tropical sprue, celiac disease, giardiasis, primary lymphangiectasia, these diseases don't have pain. And any which is actually obstructing the lumen like tuberculosis, Crohn's disease, IPSID, Whipple disease, all these can cause painful cause of chronic diarrhea. Then there has to be associated malabsorption. What are the features? Carbohydrate malabsorption, there has to be generalized weakness, they have bloating, flatulence, abdominal discomfort. because of the more amount of gas, and fat malabsorption leads to loss of body fat and steatorrhea, and protein malabsorption leads to actually loss of visceral and somatic protein. As far as vitamin deficiencies are concerned, there are a series of actually symptoms according to the vitamins. We have deficiencies. Thiamine leads to beriberi. Riboflavin deficiency leads to glossitis, angular stomatitis. Niacin deficiency again leads to photosensitive dermatitis and diarrhea. Pyridoxine deficiency leads to anemia, neuropathy. Folic acid and B12 lead to megaloblastic and macrocytic anemia. So small bowel diarrhea we have to define initially, then we go ahead and see whether there is malabsorption, it is without malabsorption. There are characteristic stools, anemia, signs of deficiency of vitamins. Then we have to see whether it's a mucosal disease. Among the mucosal disease we have celiac disease, tropical sprue, parasitic diseases, IPSID, intestinal lymphangiectasia, SIBO, intestinal tuberculosis and Crohn's disease. So all these actually small bowel diseases with malabsorption we have to take into consideration. If it is without malabsorption, it is then a secretory diarrhea, and bile acid diarrhea is one of them. As far as inflammatory or non-inflammatory is concerned, if there is a fever and joint pains, then we have to think of tuberculosis, Crohn's, ulcerative colitis, IPSID, Whipple, eosinophil enteritis. All these have actually inflammatory component with them, or it can be absent, as occurs in tropical sprue, celiac disease, giardiasis, primary lymphangiectasia and other. If it is associated with blood, we have IBD, uncommonly tuberculosis as well can cause bleeding per rectum. Diarrhea, osmotic or secretory. If somebody has chronic diarrhea and you put him on a 48 hours of fasting, diarrhea improves, it stops, then it is osmotic diarrhea. Otherwise, if it continues for more than 24 to 48 hours, it is secretory diarrhea. So we can estimate the osmolarity, and if it is more, then it is osmotic diarrhea as compared to the stool osmolarity, total osmolarity. And in secretory diarrhea, it is less. So you can define which type of diarrhea it is. Among the symptoms in osmotic diarrhea, there can be perianal redness because of the high osmolarity content, and that leads to irritation. And then volume is less than 200 ml. They are totally watery, explosive, a lot of gas is there in osmotic diarrhea. And fasting, it responds, and osmolarity, it is more, and reducing substances are there, so pH is low, and osmotic gap is characteristically more than 100. In secretory diarrhea, it is less than 25, and it is again watery, non-explosive, and there is no gas in secretory diarrhea. Among the causes of osmotic diarrhea, we have certain medication, antacids, lactulose, sorbitol, very common. Then disaccharides deficiency, lactose intolerance, fictitious diarrhea with magnesium laxative and antacids of a chronic use can lead to osmotic diarrhea. Then we have secretory diarrheas. Again, all those endocrine tumors can lead to secretory diarrheas. Villus adenoma, large villus adenoma in the rectum can lead to a secretory diarrhea. Then we have laxative abuse, bacterial toxins, and bile salt malabsorption. Then when to suspect malabsorption syndrome? If there is in chronic diarrhea, if there is evidence of malnutrition, there is weight loss, significant weight loss, large bulky malodorous stools which are difficult to flush, we should think about malabsorption. If there is no diarrhea, we can still suspect of malabsorption syndrome. If there is isolated weight loss, iron deficiency, anemia, hypocalcemia, which is to be investigated, and ultimately we can actually label them as a patient of malabsorption syndrome. So how to diagnose malabsorption syndrome? Initial investigations, simple investigations like hemogram, blood chemistry, stool microscopy, normal stool for opportunistic infections, D-xylose test and fecal fat test to see for carbohydrate and fat malabsorption. Then we have certain other tests for the etiology of malabsorption. We can have small bowel biopsies, D2 biopsies, HIV serology, anti-endomycin, TTG, IgA we can do. Barium meal series also is helpful when we don't have CT angiography with us. Breath tests are there. Then microscopy and cultures of jejunal aspirates is also required to diagnose patients of SIBO. Then serum immunoglobulin should also be done to see and rule out combined immune deficiency syndrome. Then abnormal alpha heavy chains. Actually, there are few patients of these heavy chain disease, those who have chronic diarrhea. Then fecal fat estimation, Sudan 3 is a qualitative test, which is actually in clinical practice we do that. Quantitative 24 to 72 hours quantitative test, it's basically a gold standard, but not usually being done. Then we have semi-quantitative, that is acid steatocrit test. It's not widely available, and it's a simple good accuracy test, but not widely available. Sudan, it is widely available test and easily can be done. And 24 hours fecal fat test is the gold standard, but it is quite cumbersome. A normal value doesn't rule out malabsorption if these tests are normal, and there is no utility in determining the etiology of malabsorption. Somebody has got fat malabsorption, it is not, I mean, again you have to see for the what is the etiology. And in most patients, severe steatorrhea, simply doing a quantitative analysis may not help, because we know that the patient has got steatorrhea. As far as proximal small bowel mucosal absorption is concerned, we have got D-xylose test, and in this actually 50% of the absorbed D-xylose is excreted in the urine, and after an overnight fast, 25 gram of D-xylose is given. If it is less than 4% excreted in the urine, that indicates abnormal intestinal absorption. But nowadays actually not being commonly used, because we do an endoscopic biopsy and stamp the diagnosis in patients with chronic diarrhea. As far as bile acid malabsorption is concerned, the crux of the matter is like it has to be a high fecal bile acid output, which can be done by enzymatic method or chromatography. So either you actually measure it in the stool or in the serum by actually it's a labeled carbohydrate labeled bile salt which is given. So if you have less amount in the serum after 7 days, that actually stamps your diagnosis of bile acid malabsorption. And a high output in the stool actually also gives you the idea of bile acid malabsorption. But these tests are not easily available, and the best test for a bile acid malabsorption is if you have a history of cholecystectomy, if you have a history of a terminal ileal disease, might as well actually these patients to be given cholestyramine and then see the effect in 2 weeks time whether the patient's diarrhea improves or not. And then we have certain tests for steatorrhea, beta carotene levels, and then we have tests for IgA, TTD, IgA, which is actually and anti-endomycin antibody. And mind you, you have to do a IgA if you have a strong suspicion. You have to do IgA levels if the TTD IgA is negative. HIV serology, which is helpful in patients who have got recurrent infections. We have to rule it out in all patients with chronic diarrhea. And IgA levels should be done in patients where you have IgG levels to be done in patients in whom you are suspecting combined immune deficiency syndrome. And then common immune deficiency syndrome. Then role of cross-sectional imaging. This is actually required whenever these patients are painful, to rule out strictures, fistula, diverticula, and to see for pancreatic calcification. Actually, we can grade and extend the disease of IBD can be actually monitored by doing MR angiography. And in secretory tumors, actually, if a high degree of suspicion, even these actually cross-sectional imaging help to actually find the tumor. Plain X abdomen, very good in patients with defining the calcification in chronic pancreatitis. And at the same time, you can do intestinal transit study, because as such you give oral contrast to these patients when you are doing an imaging study. MR angiography and capsule, that does help in diagnosing inflammation within the small bowel, especially in chronic diarrhea patients where you have not reached the diagnosis. Ultrasound of the small bowel has limited diagnostic role. Presently it is not in any of the guidelines, but it is a research tool. And enteroscopy assisted or not, it has a limited diagnostic value. Once you do the imaging, you find the lesion and then you do it. Endoscopy helps both ways. Macroscopic lesion can be confirmed, and it can be then confirmed by doing the biopsy. So in celiac disease, you find nodular, reticular, cobblestoning appearance, and with the magnification endoscopes, we can actually see the macroscopic reduction of the villi even. And the typical findings on a white light is mosaic and reticular pattern as well as fissures, which has got around 98 to 99% specificity. This is how the fissuring is seen in a patient with celiac disease, and intestinal lymphangiectasia in endoscopic vision on a ileal endoscopy. Then These mucosal biopsies, these should be taken full thickness mucosal biopsies, and they should be 5 to 6 in number. They should be seen more from D2 and D3, and this is how actually normal crypt villus ratio is 1:3. So crypt is small and the villi are more. And as we go from mild to severe disease of celiac, you find that the villus decrease in size and the crypts go deeper. So that's how actually you classify and grade the severity. And this is the subtotal villus atrophy seen in celiac disease. Then you see past positive macrophages, and you can see in the lumen the one with the red nuclei, GRDSs. The gold standard for SIBO is diagnosis of small bowel bacterial overgrowth is actually to see the colonic count, which should be more than 10 to the power 5, and in India the cutoff is more than 10 to the power 7. Breath tests are there, hydrogen, methane, breath test. The mechanism behind is actually if the colonic bacteria come into the small bowel and you are doing a breath test, then you will get early peaks. So persistent 2 early peaks actually gives you the diagnosis of SIBO. So it can be actually glucose hydrogen breath test or lactulose hydrogen breath test. The disadvantage of a lactulose hydrogen breath test is lactulose itself can lead to a rapid transit and can cause a high false positive study. Presently, actually, a normal breath test may not actually rule out SIBO. So in practice guidelines you may not have, but it supports your diagnosis if it is positive. So algorithm for the diagnostic test for malabsorption syndrome are that initially you define whether it is more than 4 weeks, then a no nocturnal symptoms, you do stool test 3 times, you see you do giardia antigen test, fecal fat test by Sudan staining, and then you do a complete blood count, thyroid function test, B12 folic acid level, HIV serology, IgA tissue, TTGA, and then these alert test if required, and breath test also if required if you don't reach to the diagnosis of SIBO. Even you can give a therapeutic trial in these patients, and you do upper GI endoscopy, take a biopsy, you can do cross-sectional imaging if there is a painful type of chronic diarrhea, and you actually categorize which type of malabsorption it is, then accordingly you can actually plan your further test. So fecal elastase, serum vitamin B12, folic acid levels, and then serum immunoglobulin levels also abnormal, heavy chain in serum and urine, and then you actually go for bile salt chelation therapy. You can go ahead and do a double balloon endoscopy, capsule endoscopy. These are the tests actually, second line and third line test. And in third line test, when you are actually suspecting neuroendocrine tumors, then you go for special tests for those. And a diagnostic laparoscopy will put the full thickness intestinal biopsy if you are actually suspecting a transmural disease may help you in the diagnosis. So it is actually exclusion of infection. That means by doing bacterial cultures, then test for other pathogens, you can do special staining and special stool test. Then exclusion of structural diseases by doing a cross-sectional imaging. Then you will see sigmoidoscopy and colonoscopy with mucosal biopsies. And if you are suspecting a small bowel lesion, we do a capsule enteroscopy. Selective testing, in unusual cases, you can go ahead and do neuroendocrine tumors you are suspecting, you can do further tests. And empirical trials by having a low food map diet, bile salt acid binding agent, cholestyramine if you are suspecting bile acid diarrhea, antibiotics for SIBO. So I like to conclude by saying that a systemic approach including detailed history physical examination is essential for evaluation of chronic diarrhea, and to categorize the diarrhea whether it is organic or functional at first, then to distinguish between malabsorptive type from colonic and inflammatory forms of diarrhea, and to assess for specific causes of diarrhea. Screening tests should include blood tests, that is food, blood count, ferritin, TTG, and anti-endomycin antibody, thyroid function test, and appropriate stool test. HIV infection should be excluded in patients. This is my last slide. I'll go back to the, yeah. So serological testing for celiac disease, it is one of the common cause of small bowel enteropathy, should be done. CT and MR angiography, depending on availability, should be the preferred emerging modality of choice. Then hormone secreting tumors are the rare causes of diarrhea, and testing should be done only if there is a strong suspicion and other causes are ruled out. And evaluation of malabsorption syndrome can at times be challenging and frustrating, and even 20% of the cases you still may not reach to the final diagnosis and you label them idiopathic. Thank you for your kind attention. Thank you.
Thank you, sir, for your extensive deliberation. May I request you to please be seated on the dais itself.
Dr. V.K. Dixit on the dais. Dr. V.K. Dixit is Senior Professor and Head of Department in Gastroenterology at BHU Varanasi. He has been the President of the Indian Association for the Study of Liver. His topic for today's discussion is Managing Functional Dyspepsia and Where We Stand Today. I kindly request him to begin with the speech.
Thank you, Chairperson. Endoscopist, but it's very sometimes it's really a acid test for the gastroenterologist to treat the dyspepsia, which is one of the very common problems which we face in day-to-day practice. The functional dyspepsia basically comprises of the three subtypes with the presumed different pathophysiology and etiology. They are either the postprandial distress syndrome, or the epigastric pain syndrome, or it's the overlap of the PDS and EPS. Functional dyspepsia symptom can be caused, as you know, there could be a different etiology. Either it could be because of disturbed gastric motility, for example, like inadequate funding or accommodation or the delayed gastric uptake. Either it could be a disturbed gastric sensation, for example, like sensation associated with the hypersensitivity to gas or bloating, or maybe due to because of gastric and dural inflammation, or sometimes due to the psychic comorbidity and psychological factors. The diagnosis of the functional dyspepsia basically is based on the 4 criteria, which says the patient with the one of or more of the following: whether patient has a bothersome postprandial fullness, or whether patient has bothersome early satiety, bothersome epigastric pain, or bothersome epigastric burning, and if there is no evidence of strictures, that's very important, then we label them as a functional dyspepsia according to the Rome 4 criteria. Now, this is a simple diagnostic algorithm for functional dyspepsia. If a person who comes with the upper GI symptom, you take a detailed history as you do in all the cases, and first thing is most important to find out any alarm symptom. Alarm symptom may be in the form of the weight loss, it may be because of the GI bleed, or maybe because of dysphagia. If alarm symptoms are there, then of course the patient is subjected for upper GI endoscopy and other endoscopy, biopsy, etc. And if the abnormality is found, then you treat accordingly and we label them as a secondary dyspepsia. But if the person is not having an alarm symptom, then you just may be saying it's uninvestigated nausea, vomiting, belching. Simply treat the patient if needed. If uninvestigated dyspepsia, you consider for exploratory test, because some of the tests may be positive and may be rewarding, sometimes treating the Helicobacter pylori. And there is no system resolved, then you can use the other test, and ultimately you try to find out whether the patient has got primary dyspepsia or the secondary dyspepsia. So management of the functional dyspepsia is basically the key first step in the initial management is the exclusion of the possibility of upper GI cancer by a judicious application of the alarm symptom, and excluding other possible differential diagnosis of the functional dyspepsia. As I said, it is the alarm symptom. And these are the few alarm symptoms. Either it could be a new onset dyspepsia at the age of 45, 55 years of age, over GI bleed, dysphagia, persistent vomiting, unintentional weight loss, or family history of the gastric or esophageal cancer, or palpable abdominal lump or epigastric mass, or evidence of iron deficiency anemia. If they are there, then you consider them as the alarm symptom and you try to investigate them. Now, what is the possible differential diagnosis of the functional dyspepsia? Sometimes they can also mimic like that. Patient can have a peptic ulcer disease, very common, and the patient coming with a gastroesophageal cancer, patient having gallstone, inspector of rhodite dysfunction, drug-induced adverse effect, chronic pancreatitis, parasitic infection, sometimes even malignancy like SCC, chronic mesenteric ischemia, Crohn's disease, inflammatory disease, and many more. they can mimic like a functional dyspepsia. Now, what is the role of diet? Diet, I think, plays a very important role in our day-to-day system and for the peninsular dyspepsia also. So, dietary adjustment and Helicobacter pylori eradication in those who are infected can be applied for the management of all patients with the functional dyspepsia. Means you should take care of the dietary factor. You should look for whether the diet may be a real aggravating or relieving factor. Regarding the Helicobacter pylori, as I said in the beginning, Helicobacter pylori eradication treatment is definitely advocated in all guidelines for the patient with the functional dyspepsia who are infected, who are found to be positive, RUT positive, or the serology is positive, as it has the potential to improve the symptoms and control the risk of the developing peptic ulcer disease and even gastric cancer, because Helicobacter pylori is considered to be one of the important carcinogen for the gastric cancer. The symptom improvement in response to eradication occurs 4 to 12 months, and it's more evident in the patient with the EPS, epigastric pain syndrome, than patient with the post-discharge syndrome. Now, dietary adjustment of diet, particularly the intake of the food, actually frequently sometimes triggers the symptoms in patient with functional dyspepsia, with over 80% of the patient fulfilling Rome 4 criteria for PDS. Now, with the exception of the dietary fat, studies that applied blind challenges tests produce inconsistent outcome, and causal links between the specific food and the induction of the symptom remain to be established. That is the problem, because we really do not know what is the exact mechanism and what food actually basically triggers the symptoms. The most common reported food triggers are fatty food, dairy products, alcohol, coffee, red meat, carbonated drinks, vegetables, spicy food, and carbohydrates, sweets, and citrus. These are the known factors that they can trigger the dyspepsia. And this is the important chart table. You can say the fatty food is the commonest one, in the form of like 25 to 80%, in the form of milk or dairy, alcohol, red meat, as I have given in the other. So these are the percentage which I have given, that they will be contributing factor for the dyspepsia. Now, when initiating the pharmacotherapy, it's recommended to choose that agent on the basis of Rome 4 subdivision of the functional dyspepsia. In EPS, because as I said in the beginning, this dyspepsia could be either EPS or could be PDS. So you have to choose the drug actually accordingly, or you are dealing with the overlapping group to specifically treat the predominant symptom of the each subtype. So if you have a functional dyspepsia, look for the Helicobacter pylori, if and treat it. Now you describe post-parental distress syndrome, or you are dealing with the epigastric pain syndrome. Now the drugs which are used for post-parental distress syndrome is basically the prophylactic drugs. We all know, I need not to remind it, domperidone, alendronide, citalopram, topride, citalopram, etc. Then you can have other hand the fundus relaxing drug, like icosiamide or buspirone or tendusperone or other 5-HT1 agonist. Or sometimes you can use the centrally active neuromodulator like meratizine. If you gastric pain syndrome, you require most of the time the acid suppressant agent or PPI or even a H2 blocker you can give. Or if they are not responding, then you can treat the patient with the tricyclic antidepressant like amitriptyline, norepinephrine or desmorphine. If they are still refractory, then these are the groups of patients who require the psychological therapy or experimental therapy. Now the post-parental distress syndrome, the prophylactic drugs, they basically stimulate the gastric smooth muscle contraction. They propose as the first line therapy, or the prochanates, they include the 5-HT4 agonist or D2 receptor antagonist and motilin receptor antagonist. Or you can use the fundus relaxing drug. They basically target the impaired gastric accommodation, 5-HT1 agonist like buspirone or tendosperone, or an acetylcholine inhibitor like icosiamide, we sometimes use. And you can use the centrally acting neuromodulator if these two drugs they fail. For epigastric pain syndrome, basically the acid suppressing agents, as I said in the beginning, if they don't respond, then you can try the centrally acting neuromodulator, or basically hypersensitivity contribute the symptom. And that's why you can sometimes use the TCA or levosulfide or the mirtazapine, and these are the drugs which can be used for the patient if you are not responding with the acid suppressing agent. Now, this is just a simply giving a summary of the pharmacological therapy for the patient with the functional dyspepsia. So we have prophylactic agents like metoclopramide or domperidone, alendronide, clomipride, citalopram, etopride. They should be given for the PDS patient, where you think that they delayed gastric motility. and they are quite useful in these patients, except that the initial beta-chloride, these things sometimes they can have an extrapyramidal effect, or these are the side effects. Fundal selection drug like glucosamide, this thing can be given when you require a fundal relaxation, and these are the patients of PDS, they will be helpful sometimes by using this drug. Or you can use the EPS like proton pump inhibitor, which I have already highlighted. And centrally active neuromodulators can also have a place in the patient if you are not responding to whether PDS or the EPS. Now, coming to the another type of therapy, that is a psychological therapy for the functional dyspepsia. This is very important because 1/3 of the patients sometimes they may require this because they may not respond to your usual drugs. And there are different type of therapy actually which are given. I will not go in detail of them. There could be a group therapy with a focus on relaxation technique. And there are 3 arms and there are different sessions. Actually, I will not go in detail. You can have a cognitive psychotherapy. You can have a psychodynamic interpersonal psychotherapy or hypnotherapy, flexible coping psychotherapy, core conflict relationship theme-based psychoanalytic psychotherapy, and cognitive behavior therapy. I think scientists, they understand better because they are very difficult. They are different sessions of like months together, but they all found all the 7 studies which have been conducted, the patient who received actually psychotherapy, they demonstrated some improvement with respect to the gastrointestinal symptom compared with the patient under standard of medical care. So it is not clear whether the improvement is in psychiatric patient or secondary to the elevation of the GI symptom or vice versa. Now there are certain drugs actually which have been developed to deal in some patient specific therapy. Like there is a meta-analysis that included data of 3 randomized controlled trials that showed that the herbal drug preparation like STW5, which is a combination of a garden, angelica root, milk thistle fruit, caraway fruits, greater calendine, bitter candy tuft, licorice root, chamomile flowers, palm leaves, and peppermint leaves. So there is a combination, and they are giving as a herbal drug. And this is the trial which has been done as a meta-analysis, which has shown there is a decrease in the severity of the most bothersome GI symptom compared with the placebo. Now there is another drug actually, Rikunsicito. This is a Japanese Campo herbal medicine that appears to have an effect on the 5-HT and has also been studied in the functional dyspepsia. And 2 placebo-controlled trials showed efficacy in improving the symptoms such as epigastric pain and postprandial fullness or early satiety. This is Larentelimab is a monoclonal antibody that also has been tried, and that basically targets the SGI LAC8, which is expressed selectively on both eosinophils and mast cell in the patient with the functional dyspepsia. There could be either minimally absorbed antibiotic rifaximin we are using in many of the patients. It is found to be useful and which demonstrated significantly in the higher rate of the adequate relief of the gloom symptom and postprandial fullness. 8 weeks of the bacillus coagulation, like probiotic role is still there in the patient, and sometimes particularly they have 8 weeks of the bacillus coagulation M/01 and bacillus subtilis M/02. They were more efficacious than the placebo in terms of the likelihood of the symptoms improvement in 68 of patient. This is one of the studies published in the gastroenterology in 2021. Acupuncture may be tried another method in refractory patient, which meta-analysis have shown of data of 2 randomized controlled trials reported an improvement in the quality control in patients who received acupuncture, around 58 patients compared with those who did not receive or same acupuncture by stimulation of the non-defined points. Acupuncture might be superior to standard pharmacological treatment in elevating the early satiety and the postprandial fullness. Nonetheless, the author acknowledged that the need for randomized controlled trial of high methodological quantity. So friends, functional dyspepsia is a clinically challenging diagnosis due to the heterogeneous spectrum of upper GI complaint. There is a lot of overlap in the symptom with other diagnoses, and there is a poorly defined pathophysiology in the lackluster treatment option. As the scientific community continues to elucidate the causative mechanism and effective treatment option, the clinician should focus on the obtaining a thorough patient history and targeting therapies targeting therapy based on the symptom profile and possibly contributing or underlying the pathophysiological process. Thank you very much.
Thank you, sir, for your deep insights on the topic. We now
clinical practice. How can you help me?
Because they are having actually room criteria separate for the non-functional and separate for yes, and for separate for functional dyspepsia. So that is one way actually by which you can differentiate, because there are certain points which are given, these have to be done. But as you rightly said, there are many times it is very difficult because so much of overlap is there to tell whether really you are dealing with the IBS or you are dealing with the functional dyspepsia. But row criteria may be helpful in some extent to differentiate between the two.
Dr. Rajiv.
Sometimes patient history is very much suggestive of the small and large bowel diarrhea. एक पेशेंट से सर हमको साबुन के फेन जैसे आता है प्रथम, it suggests of small bowel diarrhea. Very thick mucoid secretion, नाक के पोटा जैसे आता है, it is large bowel diarrhea. You can go for and further evaluate.
You are very right. Actually, you have to go to the detailed history about how the stool is, and it comes by experience. So it's not to avoid the symptoms, because the chronic diarrhea presentation is actually passing out stool. So you have to take the detailed history of that stool, how the stool is.
Thank you, Dr. Sandeep.
Sir, that D-xylose test may not be required. You see, actually we have to see for the presence of a mucosal disease, which is defined by D-xylose test. And if you go into the history and you are suspecting it, then might as well go into D2 and D3 and take multiple biopsies to define the etiology. As far as steatorrhea is concerned, Sudan test is not a difficult test. Any pathology lab can do it actually. And the further tests like semi-quantification and quantification, they are really not required. If somebody is passing an oily stool, there is no need to do it to quantify whether the patient has got steatorrhea or not. And if Sudan test is also not done and somebody is saying that he is passing oily stools, then you must actually concentrate your mind that patient has got malabsorption, and you have to look for a mucosal disease, you have to see for a pancreatic disease, you have to see for a bile acid diarrhea. So these are the causes, 3 causes which actually lead to fat malabsorption. And what was the other question? Actually, there were multiple questions at the same time.
Diabetic diarrhea.
Diabetic diarrhea. No, in somebody having a long history of diabetes, they get recurrent diarrhea. Most of the time it is SIBO. Most of the times. But yes, there can be a colonic inertia. For colonic inertia, there can be actually a simple test of doing, you can give radiopaque pellets and. Yeah, actually, I have set up that test at my clinic only. One of my juniors have done it. So you actually cut the,
stent cut it.
Yeah, stents, and then you take multiple X's, ask the patient to go home, then 12 hours, 36 hours, 48 hours, 60 hours. And then you count the number of the radiopaque. That can be done.
Yes, Commissioner. बड़ी practical चीज़ है. अब कैप्सूल लीजिए कोई भी, कैप्सूल का जो भी सब्सटेंस आपका राजीव, आपका क्वेश्चन जो है ये बहुत कॉमन चीज़ है. प्रैक्टिकल चीज़ ये है दोस्त कि उनको ज़्यादातर फिंगर इवैक्यूएशन करते हैं वो लोग. या तो उनको SRUS होगा, तो स्टेटिस प्रोफंडा होगा, रेक्टल प्रोलैप्स होता है इनको, तो कभी कभी इन्फेक्ट हो जाता है. ये लोग बताते हैं कि बहुत ज़्यादा म्यूकस आता है, और बहुत लोग ने साइकोलॉजिकल ओवरले बहुत ज़बरदस्त होता है इन लोगों. IBS ट्रीट करने के लिए मैंने बहुत पहले, करीब 40 साल पहले बॉम्बे में कहा था कि आप रिंग मास्टर हैं, आप जहाँ चाबुक छोटा वो शेर आपको खा जाएगा. तो यू हैव टू बी इन कमांड. वो आके पहले बताता आपको, साहब देखिए विजय प्रकाश साहब को भी दिखाते हैं. इसका मतलब अरे यार तुम क्या ठीक करोगे जब ये नहीं ठीक कर पाए, ये क्या है. तो यू हैव टू बी वेरी प्रैक्टिकल ओवर देयर. दैट इज वेरी इंपॉर्टेंट. साहब को इंस्टीट्यूट का नाम बताइए, इतना पोथा लेके आएगा, वो बड़े खतरनाक हो जाएगा. जो जोर से पैर छुआ वो तो बची रहेगी.
नहीं, you have to build a confidence in the patient, in IBS patient.
संदीप, इतने इन्वेस्टिगेशन बताया, बस ऑटोप्सी बच गई
Patient, keeping in view of about 15 to 20% of gastric cancer nowadays presented in an age group less than 45 to 50 years of age. And there is a very well-defined progression of the disease from gastric atrophy to metaplasia to dysplasia to gastric cancer. And patient with gastric atrophy or metaplasia present in a vague way, like the dyspepsia-like symptoms. So where do we keep endoscopy in your algorithm?
Initially respond even after the 3 months. It's better to do the endoscopy or some investigation. You investigate these patients. As you rightly said, because that 55 cutoff is not necessary. Because in India we are seeing about the CH stomach at the early age also. Then you should do endoscopy, and if you find any abnormality, whether atrophic ascites or Helicobacter pylori positive gastritis, something like that, then you treat accordingly. And please follow up these patients. They may be having functional, they are not having any significant weight loss, they are not having any other alarm symptom. But if they are not showing any improvement in spite of a treatment for 2 to 3 months, then you should definitely investigate. At least the common investigation you can do. Simply gastroscopy may be sufficient, and then you can do some other tests like ultrasound or other things, and that should be sufficient for you to pick up some of these cases like this.
Dr. Sandeep, I like
With this, we mark the submission of our second. Please join us for the lunch. We will continue our session soon after lunch at sharp 2:45 p.m. Thank you, everyone.